So thank you. I just want to say thank you all. I'm sure nobody has a better place to be on this sunny morning than here with us. So thank you all for coming, and thank you Dr. Comer and Danielle Cornacchio and all the FIU folks who have worked so hard to put on this conference. Today I'm going to be talking to you about anxiety in children and adolescents with autism spectrum disorder. I'll be using ASD for short to keep me in check, but that's what I'm referring to as the DSM-5 label of autism spectrum disorder. Just to let you know, this is from where I hail. These are the Blue Ridge Mountains, so that's about 15 minutes from where I live, and that's their campus of Virginia Tech in May. So it's a beautiful area. If anybody ever wants to come visit and see a bit of what we do, please contact me. But it's nice to be here at the beach too. Okay. The objectives for today. Sorry, I've got multiple monitors. I'm going to just stare down at this one here. First, we're going to be talking about the development and expression of anxiety, clinical anxiety disorders in people with ASD. Second, the identification of accurate, valid assessment tools and strategies for assessment, including to assess change when you're treating anxiety. And third, understanding evidence-based treatment options. And the last 20-25 minutes or so of this talk, we'll be talking about research out of my lab, along with my collaborators, on scientific advances related to the treatment and understanding of anxiety in this population. My obligatory disclosure slide, including some royalties that might buy candy bars sometimes, and research funding. Okay. So the first section here is on the development, expression, and conceptualization of anxiety in ASD. Comorbidity. So this is a culmination, if you will, of the published research on psychiatric comorbidity in people with ASD. And I mentioned psychiatric because there are a lot of other types of comorbidity that I'm not going to be discussing today. At the bottom, I have seizures and epilepsy, but things like GI disturbance, for instance, are extremely common in ASD, as are a lot of medical concerns. Today, obviously, we're focused on anxiety and how common anxiety is. We have a huge range of estimation, prevalence estimate for how common anxiety disorders happen in kids with ASD, 30 to 80%. Now that's not a very satisfactory answer when you think of, well, how common is this? To put it in more concrete terms, our best estimate right now is that somewhere between 1 in every 2 to 1 in every 3 kids who has ASD also meets criteria for at least one anxiety disorder. Please note, we do separate out OCD there, so that's not counting per the latest DSM edition OCD. I want to just kind of put that in perspective for a second, okay? When you're working in a generalist clinic and not a specialty ASD clinic, you do see differences in terms of the types of comorbidities you get. For instance, bipolar disorder, there's no or very limited research evidence at this time to think that bipolar disorder, for instance, is much more common in kids with ASD, but it's going to be more common in a generalist outpatient clinic when you see a client with ASD as opposed to when you're working in a specialty autism clinic. Similar for the other disorders here. So it kind of depends on which site you're in. Okay. Anxiety and autism, what it is and how it develops. I have this slide here because I think it's really important to step back sometimes and think about the phenomenology of anxiety. Connor Kearns and other researchers have done a wonderful job at looking at the different ways, to quote the term atypical expression of anxiety. The jury is still out on what is and is not anxiety, but we know that anxiety in autism, just like in typically developing kids, can be expressed a lot of different ways. I'm not sure if you can see all the images real clearly, but at the top I've got the boy who's in bed and he's got all of his objects lined up. And you might think of this lining up of your favorite objects as kind of a hallmark characteristic of autism. okay? But you can also see this, and very often do see this, as an exacerbation of anxiety and further retreat into one's restricted interests and repetitive behaviors. Then I've got the image showing self-injury, okay? We know from research out of my lab and others that self-injurious behavior, and I'm not talking the stereotypical self-harm, scratching and head banging and that kind of thing that we think of in lower functioning people, children with autism, but more of NSSI as it presents in typically developing teenagers is associated with anxiety and emotion dysregulation. Avoidance of gaze, again, well gosh, that could be both autism and anxiety. Okay, so store that as I kind of go on to the research base here, please. All right. So the basics, this is like the 10,000-foot overview of the last 12 years or so of research on anxiety in autism. Which types of anxiety are most prevalent in autism? There is inconsistency in the published research, all right? There's a lot of debate, but for kids, we think it's most common to see specific phobias, followed by generalized anxiety disorder. For teenagers and young adults, we see more social anxiety disorder and GAD. So that is not that different from what you see in the typically developing population, where specific phobia usually rears its ugly head first, developmentally. The same thing we believe currently is happening in autism. The life course of anxiety in autism. Usually the onset is during childhood or early adolescence, but here's the kicker. And this is what I think is critical if you are working with these families. It is not a developmentally restrained phenomenon. It persists. 1 in 3 adults, and these are verbal adults for the most part, okay, most of this research, big caveat, it's restricted to people who don't have co-occurring intellectual disability and who are at least minimally verbal. But 1 in 3 adults meets criteria for an anxiety disorder. So it's not something that you can just attribute to a developmental, time-limited phase of life. Okay, the basics too. What predicts anxiety? Number 1, higher cognitive ability and higher verbal ability. Now, there has been consternation among clinicians and scientists alike. Well, might this just be reflecting the fact that they are better able to introspect and report on their symptoms? Because you think about any of the internalizing problems, and you do often, as a clinician, have to rely on introspection, ability to have insight into your own feelings and distress, right? Well, we've gotten better at this through use primarily of psychophysiological measures. But even when you don't rely so much on the self-report, you see more difficulty in those individuals who have higher cognitive and verbal ability. Number 2, there's mixed evidence about severity of autism. Okay, so yes, it's a diagnostic label, but like with all of our diagnostic labels, you have variance in how severely impacted a person is. At this time, although there's mixed evidence, the preponderance, the weight of the evidence, is that more severe ASD is associated with more problems with anxiety as well as with depression. And that's especially so for social anxiety disorder. 3rd, gender. Again, it's one of those things that I wouldn't say definitively on this date, but who knows, maybe in the next year or 2 we'll know more about this. Right now, we're in favor of females tend to experience, both in adolescence and in early adulthood, more problems with anxiety than males with ASD. Why? Why? Maybe this is the money question, right? So why do autism and anxiety so commonly co-occur? There's probably at least 50 different theories about this in this room, and I would love to take the time to be able to get at those. What we have from the research right now is that it's likely not symptom overlap. For a long time, we were very concerned about the flip side of diagnostic overshadowing. So diagnostic overshadowing is essentially when one diagnosis overshadows or prevails, and we can't or we don't allow ourselves to see the possibility of another disorder being present, okay? That very often happens with intellectual disability. And it happens too with the other neurodevelopmental disabilities. When we don't double count, when we're extremely stringent about anything that could count as an autism symptom can't count for anxiety, you still see heightened prevalence of the anxiety disorders. Okay, so we just simply can't attribute it to that. Familial transmission. We know, and we have known this for decades, okay, from Connor's original writings on this, you see more anxiety in first-generation relatives and the parents of kids who have autism. And also, when a parent has autism and they have offspring, those offspring are more likely both at higher risk for anxiety disorders and autism. But we don't know, what we don't know here is that this risk, this heightened risk, is purely genetic in origin. Okay, there might be something about shared environment. Third, this possibility that ASD itself is a risk factor for anxiety. I'm going to get more into that in a moment, but there's, you think about things like need for sameness, resistance to change in routine, difficulty with emotional insight and perspective taking in other people. In many respects, if you were not thinking at all about autism, these same processes could contribute to anxiety. And fourth and finally, shared risk processes. This is where the bulk of the clinical research is happening right now. So what are those proximal processes that might affect both autism and anxiety? So things like base physiological hyperarousal, core emotion dysregulation. So, all right, we'll move on. Because I tend to think in images, I think this is a helpful figure to put this into context here. So we think of autism and anxiety as very related constructs. They're separable, okay, but they're still distinct. So this is that third bullet where the autism might give rise or heighten risk to the experience of anxiety. Come on, there we go. And this is the other side of that, these shared risk processes. So amygdala hyperreactivity, alexithymia. Alexithymia is the inability to access and label one's own emotional experiences. And impaired emotion perception, both expression and recognition, if you're thinking in terms of RDoC. Okay, so let's jump to some conclusions on this based, it's not really jump into the conclusions because we are basing this in research, but, sorry, I'm using my slides up here too, that's why I keep having to look down. So number one, anxiety in kids with autism is common. Okay, we can all agree on that, I think. It is likely more of a trait than a state-based response. Okay, and that's a little bit different than most of the anxiety disorders that we think of in kids. There is this underlying neuroticism trait that's core to all anxiety as well as depression. But in autism, we have more evidence right now that it's fairly stable, chronic, and trait-based. 3, changes in the expression over the course of development. Yet it's stable, okay? So this heterotypic continuity. The anxiety is there, but over a given child lifespan, it might be expressed in many different ways, including diagnostically. It doesn't have to persist as a specific phobia, for instance. You might see that specific phobia morph into something more akin to social anxiety disorder as adolescence approaches. And fourth, it may have a unique presentation in autism. Okay? And there's lots of active research on all of these points. All right, so we're going to move on to the second section here on assessment and diagnosis. We really don't know what we're doing in terms of treatment, development of EBTs or dissemination if we can't measure them. Good measurement is the bedrock of all that we do in clinical science in terms of treatment research. So it's fundamental too for practice. All right, so how do you conceptualize anxiety? Do you think of things like insistence on sameness? You can raise your hand or you can nod. And it's okay if you don't. What about social avoidance or withdrawal? Is that something that, like, if I see that in a client or a student, that flags for possible anxiety, right? And probably similarly for adherence to routines. Anxious people have a safe way of doing things, okay? And they tend to not veer too far from that, regardless of the flavor of the anxiety disorder. Do all of these things also hit for autism? Right. So we have to be real careful in how we conceptualize and how we measure is the bottom line. Okay. So what I'm going to be doing in the next 2 or 3 slides here is talking about the most commonly used measures. I shouldn't say just commonly used, but these are also the measures that are available clinically and that have, I would argue, pretty decent data on their psychometric qualities and clinical validity for measuring anxiety in kids with autism. Rating scales, the ACEBA scales, the battery, the CBCL has been used quite a bit to measure anxiety in kids with autism. The MASC and the MASC-2. There have been a couple of studies in the last few years looking head-to-head, kids with autism and kids who have anxiety who don't have autism. They don't operate completely equivalently in terms of their construct structure, but similarly. The SCARED. This is used, of these measures, I think the SCARED is used the most internationally, whereas in the United States we tend to be biased toward like the CBCL and the MASC. And then the CASI. The CASI is a bit different than these others. This is in the public domain. This has had quite a bit of research originating out of the RUP group. And Larry Scahill and others are working on a modification of the CASI that's not in prime time yet. But what's nice about the CASI is it's dimensional. It's not tethered to a specific anxiety disorder. It's in the public domain, and it's not conflated with symptoms of autism. So it cuts those out. In terms of interviews, probably the most widely used interview, and this is no surprise, is the ATIS. But we've seen this in multiple clinical trials now, and it seems to operate like you would expect it to. The anxiety disorder interview schedule. I have found, like, as a clinician, and also in the clinical research that I do, especially with kids and teenagers, I tend to have parent and child in the room together. For many reasons, not the least of which is the difficulty with historical reporting that the kids often have. Okay. I do want to just insert a small caveat here. When we rely on parent report, as we often do, for assessing child anxiety, parents tend to have low rates of endorsement of items that rely on the child to self-report, verbalize, or introspect. Okay, so as a clinician, just be mindful of those items where you're getting at things like GAD. Okay, because you might need to branch out and get more behavioral there. You know, what can he approach? What physiological signs are you seeing? Shaking, trembling. All right. Behavioral avoidance tests. There goes my slides again. This is a nice one, and I talked some about this in the workshop yesterday. Because you can measure in a very concrete way how close a child, for instance, is willing to get to feared object. And it's a nice way also if you're going to be building that into your exposures for treatment. Functional assessment. As I mentioned a few slides back, sometimes the behaviors that we might ascribe automatically to autism could be actually a manifestation of anxiety, or if not just a core manifestation, exacerbated by the anxiety. So monitoring things like restricted and repetitive behaviors and rituals and reassurance seeking and verbal rituals, especially engaging the parents in this back and forth. And finally, modifying the SUDS, the subjective units of distress scale. I have one image there that's a pretty standard SUDS thermometer, but you can be creative in this and use pictures or even manipulatives to get at how distressed are you feeling right now. It doesn't have to be 1 to 10. Okay. So when we think of assessment and diagnosis of anxiety and autism, I encourage us all to think outside the checkboxes and to get creative with our assessment. Number one, this is I think the cardinal rule, is consider the timeline, the history of symptoms and symptom progression. What counts as a new symptom? What can you clearly not capture in ASD? And then what is the gray zone around this if you think of a Venn diagram? Number two, parent-child agreement is extremely poor in this domain, in assessing comorbid problems, period, but especially so for comorbidity in autism, okay? It's even lower. So I tend to look for things like, okay, can I get another third-party reporter? Can I get more observational data? And I'm not going to worry too much about, do I see agreement in terms of exceeding threshold across raters? I look for patterns. Okay, do I see the same type of pattern across my reporters? 3, be extremely mindful of possible depression. I think right now we're at a point in the field where depression is probably more overlooked than anxiety. And we know from adult retrospective research that anxiety, just like in typically developing populations, it tends to precede depression. So be very mindful of possible depression in this group too. And number 4, assess dimensionality. I know I have been guilty of this in my own research, and I think others who kind of are working along the same vein are as well. We have relied so much when we think of the 3 primary dimensions of anxiety, okay, of the physiology, the behavior, and the cognition. In the world of autism research, we have focused so much on the behavioral and the psychophysiological because they're easier to tap, especially in a population that's defined by poor insight and minimal verbalization, okay, of own symptoms. We can do things like these behavioral approach tasks, and we can tap psychophysiology really good in non-invasive ways. But to get at the cognitions, okay, that's a lot of times, especially with the new DSM, you think of social anxiety disorder and how much the FNE criteria is highlighted now, the fear of negative evaluation. We really have to know how to tap this better. Okay. All right. And I think this is my last slide on assessment. I might be lying on that. Reliance on accurate verbal communication can hamper accuracy. Okay, so don't rely too much on verbal, especially self-report. But I do think self-reports are important. Okay, they shouldn't be automatically discounted. If there's a whole bunch of seats up here, if you all want to take a seat, sorry. I didn't think of that at first. In getting self-reports, what I have found helpful is to make sure that the terminology that's used in the reports is understood by the client. Okay, so if that means you have to kind of develop your own, like inserting the words that that client uses instead of the words that are on the questionnaire to make sure that they understand it, that can help in getting a more valid report, if you will. So make sure the technology is known and hone in on changes from baseline. Okay. And then finally, questions to aid differential diagnosis. As I mentioned a little bit ago, I always look at, are the symptoms better accounted for within the ASD, okay, so that we aren't counting something that shouldn't be counted. Do the mood and anxiety symptoms contribute to impairment above and beyond the autism? When an anxiety disorder is present, we know from multiple research studies now that it does contribute uniquely to the functional impairment above and beyond that attributed to autism severity alone. Are the symptoms transient? Is this new? Has it been sustained long enough to meet diagnostic criteria? These are not easy questions to answer in most intakes. And what is the anxiety or that symptom tethered to? Is it to the object, or is it to something that that object does in relation to autism? Okay? Is it that I am afraid of object, fill in the blank, or that object prevents me from engaging in this ritual, or taking my prescribed route, or engaging in my restricted interest? So that's a little bit more nuanced than kind of straightforward anxiety assessment. All right. So in conclusion on assessment, don't automatically discount self-report data. Okay. Use presses whenever possible to try to bring the symptoms into the session, into your assessment. Number 3, beware that symptoms of anxiety may very well present atypically. Okay, so not as you would expect social anxiety or a specific phobia to present. And finally, as I've said before, get a really solid timeline about the symptoms. What changes and what are the precipitants to these symptoms, to these behaviors. Okay. Treatment. I'm going to talk a little bit about empirically based approaches and also the road ahead, kind of the cutting edge research. And there is a lot of it to talk about. So obviously I'm going to be focusing on depth right now instead of breadth. Yeah, I think that's, I just like the visual here. And in terms of like getting out of yourself in session. And sometimes it can feel like you're trying to perform an act of magic here. Okay, the research. So here's what we're going to be talking about for the next 15 minutes or so. What approaches have the most research base to support their use? And I think this is important for all of the clinicians and the teachers, educators in the room because of informed consent. You want to be able to tell your client, your parent here, this is what has the most support. This also has support. We're going to try track A. We're going to see how it goes and switch gears if needed. So that's one major goal of this. Second, we're going to talk about what do we know about mechanisms of change. Okay, we think of parsimony a lot in the work that I do, and we have so many manualized curricula. It's very stressful when I put on my clinician hat to think, okay, for this case, what's the right approach? And at what point do I deal with this negative life event or this stressor or this thing going on over here that doesn't fit in the curriculum? So as many people are doing, we are too trying to say, what are the main processes, the mechanisms that drive the pathology, and how can we target there? We're going to be talking about personalization of treatments. That's sometimes called personalized medicine or individualization. If you want to think about it at the basic level, it's when does it not work? Okay, and who is it most likely to benefit? And then finally, sustainability of treatment effect. Okay, so first, the current research on treating anxiety in people with ASD. Okay. Cognitive behavioral therapy for anxiety and ASD. This is currently the winner by a long shot in terms of evidence base for treatment. There have been a couple of meta-analyses published, several case studies and small N designs, single subject studies as well, and now quite a few RCTs. Most of these RCTs have been published with people who are 12 and under, but branching out more into teenagers, okay? So this is kind of the take home, if you will. There is a research base, but as with all research at this stage, it's not to dissemination, and it's on a fairly restricted sample. And you can probably guess what that sample is. We're talking about people who don't have co-occurring intellectual disability in pretty much every study here, and people who are at least minimally verbal. Okay. So the preponderance of evidence for the effectiveness of CBT. I'm not talking about statistically significant change here, but clinically significant or meaningful change. The effect sizes tend to be pretty impressive, and they're definitely more so for parent report data as opposed to self-report data. Across trials, we see pretty large effect sizes for change in anxiety. Okay. Maybe is a misnomer, perhaps. I'm talking about mindfulness and acceptance-based interventions and the emerging evidence to support their use as a treatment option for anxiety and autism. They are inherently transdiagnostic, and this is kind of a third wave CBT approach. Many of you I know are familiar with mindfulness and acceptance-based interventions, and they don't necessarily contradict CBT in kind of traditional CBT, but they're a bit different. And we're starting to think more now about how do we integrate traditional CBT with mindfulness. In autism, mindfulness and acceptance-based interventions appear to reduce anxiety and improve social responsiveness. Okay, there's been a few trials on this now. And also reduce anxiety and depression and increase positive affect in adults who have autism. If you can't read the cartoon here, I can't either, actually. Every day for me is an uphill battle, but on the positive side, it's great for my glutes. I think this is funny, yes, but it's also really apropos to thinking about treating anxiety, because in many respects, if you think of anxiety in autism as being this trait, this fairly chronic beast that might change and form over the course of development, the obvious question is, do we need to be thinking about treatment in a different way? Almost like immunization with boosters, okay, as opposed to treat to cure. All right? Normally, when we go into treatment for people with autism, our goal is not to make the autism go away. Okay, that's not the point. And this is partly why it's categorized as a neurodevelopmental disorder. But for anxiety, we very much do. All right? So I think it's really important for all of us as clinical scientists and with our individual clients to be thinking, what is the long-term likelihood of a sustained effect here? So why might treatment effect not persist? Number one, if anxiety and mood disturbances are actually a manifest of poor emotion regulation. You remember the slide that I showed of the Venn diagram here. If you have a shared pathophysiology of impaired emotional regulation, and that is so core to the ASD itself, if you don't target that, okay, if you don't target the proximal risk process, would you expect targeting something further down the road to have a sustained effect? Well, maybe not. Similarly, the one-directional arrow, okay? If ASD contributes to the experience of anxiety, well, things like, excuse me, theory of mind impairment, deficiency in emotion recognition and emotion expression, alexithymia, and also the peer rejection and the influence of the social group in childhood and adolescence. You do not very often get a chance when you're 13, 14, 15 to get a transplant of your peer group unless you switch schools or move to homeschooling. All of these things might also contribute directly to the experience of anxiety. Okay. So I think I've belabored that point enough, but it is important to look at sustained effect. Okay. Okay, so I'm going to come back to that in just a second, but when we talk about individualizing interventions, I want to talk for a second about MASSI. MASSI is a treatment program that I developed with some of my colleagues years back. It's the multimodal anxiety and social skills intervention, and we have done a few studies on this now, including a fairly small-sized RCT with 30 teenagers with ASD. It's a modular-based treatment that has 12 to 14 individual sessions co-occurring with 7 group-based sessions. And I'm not going to get into all the details on what MASSI is and the design of that trial right now. I wanted to put up here the basic data on efficacy in terms of the primary outcomes and clinical significance, but that's not the point today, okay? MASSI, you can read more about it if you want to. What I want to focus on right now is this. Okay, so this is the study design. All right, so the participant flow of randomization. And then what I want you to mostly pay attention to is that we had this fairly small group of 30 adolescents who met full criteria for ASD, well characterized. They were randomized to either the waitlist condition or to receive the treatment immediately. Everybody, after receiving treatment, got assessed 3 months after treatment ended and then 1 year after treatment ended. This is just the consort flow, so you know kind of where people went at different points. I won't belabor that. It allows me to switch. Here's what I want to talk about. Okay. So this figure shows the CASI-20, okay, the Children and Adolescent Anxiety Symptom Inventory, 20 item. Again, this is the scale that was originally about 6 years ago modified for children and adolescents with ASD, so none of the symptoms that are tapped with the CASI double count, if you will, for autism. Before I get into the effect of the state trait anxiety inventory here, what I want to draw your attention to is just these two slopes. And I'm not sure, yeah, it'll work here, cool. So this is during treatment, okay? Pre, mid, end, 3 month, 1 year, okay? If you were to squint and not pay attention to these 3 different lines here, the takeaway message is that we see a significant reduction in parent-rated anxiety symptoms, but perhaps more important with respect to sustainability, the reduction persists. So this is hierarchical linear modeling, and then we compared these 2 slopes against each other using a wall test, and it's non-significant, meaning this slope doesn't return to pre-treatment levels. Okay? It doesn't continue to decline, unfortunately, nor does it, I wouldn't argue that that's a flat line either. The treatment doesn't sustain as it was right after treatment ended. But overall, I think that's pretty good news when you think of the chronicity of both anxiety and autism as a neurodevelopmental disorder. So now we'll talk for a second about the state trait anxiety inventory. This is a measure that's probably familiar to many of you. And what we were looking at here is primary caregiver anxiety as it predicted sustained effect of CBT for the kids. And I was pretty shocked at this because I didn't go into this. This was like digging of well, what predicts? The only level 2 predictor that had statistically significant predictive power for anything post-treatment was primary caregiver anxiety. But it wasn't in the direction I would anticipate, okay? Those parents, I'm going to point my clicker at Dr. Comer in a second there. That colored line, that pinkish line, the most anxious parents, okay? So standard deviation above the mean. So the kids who had the more anxious primary caregivers actually showed us a more sustained effect of treatment. This isn't anything that I would say, oh, this is groundbreaking. It's not. It has to be replicated. But I think it deserves attention of why might this be, okay? Is it that doing more in terms of practices outside of session, or perhaps doing more after treatment ends on this front? All right, enough on that. So I'm going to revisit now this idea of cognitive behavioral therapy versus mindfulness and acceptance-based interventions. With CBT, above all else, what we're doing is to very intentionally and directly change the content of our cognitive and emotional events. Okay, so this is a picture that kind of adeptly shows reappraisal. One person says broken and the other person says, okay, I can see it different. Right? In mindfulness and acceptance-based interventions, we're not so much seeking to change the content, but we're trying intentionally to change our relationship to these cognitive and emotional events. They're separate from self. I don't have to change. I just need to be aware and acknowledge. Okay. All right. So treating anxiety in autism, I'm going to have 2 slides because the workshop yesterday was more about the treatment. But clinically, these are like the primaries, I would say, of what do we need to be thinking about when we're trying to treat anxiety in kids with autism. Core strategies. Number 1 is teaching emotional awareness. And this is really hard. Okay, teaching emotional awareness or insight to kids who have autism. I think it's oftentimes complicated by medication, especially when they're on when they're polymedicated or on some of the antipsychotics. But teaching awareness and being aware of when medications or other situations might be dampening their ability to access their internal states. All right, number 2. teaching a breadth of strategies or emotion regulation strategies or broadening the repertoire of what they have at their disposal to choose from. We don't see a lot of reappraisal. And we have studied this now in kids, teenagers, and adults with ASD. And reappraisal is not typically a go-to strategy for people with autism. And that's probably not a big shock, all right? But what's important is teaching multiple strategies. And reappraisal shouldn't be the only thing that's the go-to either for any client, but sometimes there's going to be a place for problem solving or for changing the situation or, as we talked about yesterday, for suppression. Third, focus on strengthening use of antecedent-focused strategies. So this is hearkening back to John Gross's process model of emotion regulation. So it takes less resources, less energy to change things before the emotion event occurs. All right. Okay. Exposures. Exposures, so critical to CBT for treating anxiety in typically developing people. And none of the published research that I showed several slides back on like the RCTs and the case studies, they didn't omit exposure from this. But I think there's still debate, like the jury's still out on what the best way is to do exposures. How you present it to the client. I have, as a clinician, experienced a lot more resistance from some clients with ASD to the idea of doing exposures that I typically get for typically developing clients. So you do have to face the fear. I think that oftentimes the exposures take longer. They just go a lot slower, both within session and throughout the duration of treatment. The treatment might actually take quite a few more sessions. The research on the impact of exposure is a bit equivocal at this point, and in vivo exposure seems to be where the money is, okay, not so much imaginal exposures. Oh, I'm sorry, I wasn't on the right slide. Environmental modifications and triggers. So we think a lot of times in treatment of anxiety of increasing flexibility and getting a person to kind of develop outside of their routinized behavior or their safety behaviors, if you will. And we know also that routines are so important to many people who have autism. And so this is a bit of a paradox, I think, in the clinical work we do in this domain, that I'm often not fighting a routine, but I'm trying to build in how do I address the anxiety into a more healthy or adaptive routine. So it's working with the routine, not trying to get rid of it so much. Sorry. And then the last bullet here, thought challenging and restructuring. This, in my experience, I think the distortion or the go-to that's most common in the teenagers, especially with ASD, is this tendency to engage in black or white thinking. This all or nothing. There's no shades of gray. There's no in between. So a lot of times that's the distortion that we end up targeting primarily. But it's not the only one, and I think it can be really hard for our clients to get to the idea of thought challenging and restructuring. I also think it's the case that not every client is capable, at least not at the beginning of treatment, to go to the cognitive aspect. Sometimes we need to stick with the bottom, with the emotion regulation, with the basic arousal management. Okay, now I'm going to be switching gears a bit and talking about some current research. This is primarily work that my collaborators and I are doing to, again, get at these mechanisms and individualization of treatment. So targeting underlying mechanisms of treatment. So in treatment, it's a process that's responsible for the observed change. Okay, this is a little bit different than a mediator of psychopathology. Which is something that we think of as underlying the manifest problem. For example, attention bias might be a mediator that underlies anxiety. There are many, many candidate mechanisms for the treatment of anxiety in people with ASD. I'm going to be targeting or talking to you about 4 of these in the context of several different research studies. So I'm going to try to do this fairly quickly. This is just to give you an overview. So FER, FEE, alexithymia. These might be terms that are somewhat new to you. FER and FEE, facial emotion recognition and facial emotion expression. These are both within the RDoC, okay, within the social domain. And they're both related to alexithymia, such that both recognition and expression atypicality have been linked to alexithymia. Alexithymia is this, again, inability to access, label, identify your emotional states. And we know that these processes are linked up to ineffective emotional social responding. Okay? About half of people who have autism also have alexithymia. So it's extremely common. And we know also that recognition and expression of emotional expression non-verbally is impaired in most individuals with autism. Second is fear of negative evaluation. I mentioned this a few minutes ago. Fear of negative evaluation is the primary cognitive component of what disorder? Thank you. Social anxiety disorder, okay? So it's really important, again, that we target not just the behavioral and the physiological, but also the cognitive domain. And then third, impaired emotion regulation. So these are the mechanisms that I'm just going to be talking for a couple minutes about in terms of how we might want to target that. Now, you guys, somebody needs to be designated to like yell at me when I don't click the slide ahead, because that would have made a lot more sense if you had seen what I had been seeing. All right. Sorry. I mean it. I've got kids. I'm okay with getting yelled at. So number 1, targeting the mechanism, emotional expression and recognition. So as I've said, FER and FEE difficulties are likely interrelated. Okay? So if you are impaired at recognizing an emotion in your partner, you are also likely impaired at showing an emotion, and vice versa. We know it's also related to social competence in kids with autism. So what we've been trying to do is understand the tether between recognition and expression and how this relates to eye gaze. Okay, eye gaze is important for a lot of reasons in autism, but it's so critical to what we pick up and perceive in our social environment. So if any of you are gamers, we are using the Kinect system heavily and now the Kinect 2. And it's nice for many reasons, but so many of the kids that we work with in our research and clinical work enjoy anything that has to do with technology, okay? So we tend to gravitate there too, but it's non-invasive and it's super low cost. Like you can get a box for about $120 right now. And it allows for pretty accurate emotion identification. So let me just show what I'm talking about here. The images at the bottom here, we have cartoon images, we have avatars, and then the face that you're seeing on the right, this is what the Kinect grid looks like. This one's going to make more sense to you. So on the left here, what we have is a regular computer, a desktop. And then we also use a Tobii mounted eye tracker. On top of that, we place our Kinect box. And then what's nice with the Kinect is it allows you to do this facial emotion expression detection in non-frontal views. So you can apply the mesh, a 3D mesh essentially, to profile as well as full frontal. And then the image to the right is one of our graduate students actually who is willing to be famous by showing this here. The Kinect, we're using machine learning and featured reduction. So there's 121 points. And connecting these 121 points are 206 specific edges. And what we're trying to do is reduce these edges to those which are most saliently predictive of discrete emotions. Okay? So it's really kind of basic math and bringing it down to how can we most accurately and quickly give real-time feedback to kids when they're interacting with Kinect on are you showing the emotion that I'm trying to get you to show. So that's what we're doing in our horribly named intervention called FEET. It's facial emotion expression training. And I'll just give you a sense of what that looks like. Okay. So addressing it, facial emotion recognition and expression. All right, so the the feet within a given session, it progresses from these cartoon-like characters to real humans to these situations that have no facial features. The subject, the child, is instructed just show with your face what I'm feeling. Show with you. We avoid the word emotion, okay? Just show with your face what I'm feeling. So you can see right there, it involves the recognition and the expression. And nobody yelled at me again, so this is what happens. So you can see the visuals as they progress to these kind of further removed stimuli. And Jose, you got me in the back there? This is the last.
It's dark here in the woods, and I hear something growling behind me. Ah!
Okay, so do you want to show me that, what I'm feeling? Show with your face. Good. I'm getting some of it. So this was perhaps one of the most fun studies that I've ever gotten to develop because I got to use my kids' voices for these. But you see what we're trying to get at here. And it's pretty cool because now we're able to map onto human-coded emotional expression to connect-coded. And we're getting good data that connect, lo and behold, can in real time detect what can be pretty painstaking and time-consuming for humans to code in terms of emotion expression. Okay, so this is getting at the facial emotion recognition part of it. So this is the FER, FEE alexithymia mechanism bullet, if you remember. So for this, we are using EEG. You can kind of see on the model, I always use my grad students as the guinea pigs for their images. The top, he's got on the EEG cap. On top of that, he's got Microsoft HoloLens. If you're not familiar with Microsoft HoloLens, it's a little bit less creepy than Google Glass. And so you've got this mixed virtual reality scenario. So if you've ever done a mixed virtual reality, it's wonderful because if you're like me and you go into a fully immersive virtual reality, you immediately get sick. Okay, you just can't do it, you're on the floor. You avoid that kind of side effect with this mixed virtual reality because you see these extremely lifelike avatars interacting with you, with other humans in the room, and they move around the furniture, they can sit at the table with you, and it's a wonderful opportunity to practice not just things like emotion recognition, but also exposures, okay? Now this all sounds, I know, very sci-fi, okay? But it's coming, and it's gonna be like a thing, I'm sure, within the next 24 months or so. So you see on my model here, he's got the EEG cap, the Microsoft HoloLens, and then we're tracking psychophys heart rate, galvanic skin response. I'm blanking on the other indicators right now on his wristband. So what our subjects are doing in this study, we're working with young adults who have autism, and their job is in these extremely brief sessions, they engage with avatars. Their job is to detect the emotion that the avatars are expressing non-verbally. They get feedback real time via the EEG on how accurate they're doing. So why do we think that's important? Because we're circumventing alexithymia, all right? We don't have to rely on their ability to verbalize what they're feeling. We're detecting it at the neural level. So walking around the room and engaging with these avatars who are in interaction with other avatars showing entirely facial, non-body emotional expressions. So I think it's just really cool that we can start to use technology to get at these things. But I'm going to move us on. Okay. The second target mechanism that I want to just briefly talk about is fear of negative evaluation. So this is something that's near and dear to my heart, especially in public speaking engagements. So we know that there's atypical social attention in people with autism, kids through adults, okay? A lot of the work from Warren Jones and Ami Klin, other people for many years now, has shown that there's something atypical. And at the very base level, we know that there's less gaze, okay, to socially salient stimuli in the environment than compared to people without autism, right? But what we don't really have a good handle on is why this is. And most of the research has indicated that it seems to be a lack of appreciation or salience for social stimuli, that it's just not that important, I don't need to attend to it. But there's also the flip side of that story, that there's some research that shows we have hyperarousal, okay, at the neural level to social stimuli, that we see less habituation, especially to anger and fear, compared to people who don't have autism, and that we people with autism misattribute anger or other negative emotion to neutral faces, okay? So it seems to be that it might not be nuanced enough and capture the heterogeneity that's in autism if we just say social information is simply not salient enough. Well, maybe it is salient for some people, and we have to understand why that is, what drives that. Okay, I'm going to speed up a little bit because I got now a 4-minute mark, I think. So this is another study that we did a few years back. Pretty small. We had 15 teenagers with autism and 18 teenagers who are healthy, no autism. We saturated both samples for social anxiety. We used the NIM-STIM face set, so these are well-validated adult still images showing the basic emotions. We had 2 tasks. I'm going to be talking about the Posner type task where we had 2 images side by side, negative and positive, or neutral. We actually use the calm images from NIM-STIM against the negative, followed by a fixation cross. And there's obviously a lot more to the research than what I'm showing you today, but I'm, again, giving you the overview here. What we found, okay, so we hypothesized that the fear of negative evaluation in autism would be related to increased or greater gaze, fixation duration to these socially threatening stimuli. And we did indeed find that. I'm going to back up for just a second. When we didn't control for FNE in these groups, we found no group differences in terms of fixation duration, and these are all high-functioning teenagers, okay? When we controlled for fear of negative evaluation, that is when they predicted, based on the extant research, that's when that group difference arose for us. But I think what's more interesting, perhaps, is that fear of negative evaluation was indeed positively associated with fixation duration to faces showing disgust and faces showing anger. Okay? So this is important for several different reasons. It's not a global effect, okay? It's not across the emotions, and we did not find this effect with the same measures when there were parent report. Okay, so it's something about the kids' recognition or appreciation that I have this fear, this uncertainty, and I have to speculate if maybe it's because of vigilance. I don't know what's going to happen, so I have to watch this more. But we did, and maybe this is like the second just take-home finding from this. When we broke up these 4-second face presentations into 8 epochs of 500 milliseconds each, we see in the last 2 epochs a sharp drop off for those kids, those teenagers with ASD compared to the typically developing teenagers. And again, both samples are highly socially anxious, but they're withdrawing. They're withdrawing faster than the typically developing kids. All right. I only show this in here because I think whenever you have small samples like this, you have to make sure that you're not having some outliers drive the effect. And that wasn't what we had here. So basic conclusion, maybe social stimuli are not universally ignored or non-salient in people with autism and kids with autism. So I think considering these data, along with other data from other labs showing that, this increased hyperarousal, especially when you have direct eye-to-eye gaze, okay, decreased amygdala habituation to socially threatening stimuli, and increased skin conductance when faced with social stimuli. We need to start considering further the role of arousal and anxiety on social behavior. They go hand in hand. Okay. Then finally, emotion dysregulation. So I think more and more that emotion dysregulation is a proximal risk factor, if you will, for anxiety, and emotion dysregulation is kind of like so prevalent in people with autism. This is just my way of thinking about this. There's a lot of different processes that are primarily biologically rooted that contribute to emotion dysregulation that can then manifest in a host of difficulties like NSSI, self-harm, anxiety, depression. Okay. And to get at that, we are starting to 2 months ago, opened up a new cross-site trial that's targeting a mindfulness-based intervention for teenagers with autism to target anxiety and a host of other difficulties. I am going to get kicked off the stage in a moment, so I'm going to try to, yeah?
Yeah, you have certainly have a bit more time.
Oh, okay, good. Whew. So, best clip ever. So I think it's important to identify moderators of response. I fail to understand why it always gives you pleasure to see me proven wrong. Okay, so yes, if you do clinical science and you think this is our best treatments, and even with our best treatments, we know that not all of our kids respond. We have to start figuring out why this is. Why do we have an unacceptably high non-response rate? Okay. And so to get at that, part of what I've been focusing on is this idea of individualizing interventions and understanding moderators or predictors of treatment response. And it's such a necessity in ASD because ASD, I would argue, more so than a lot of other conditions in the DSM, is just so darn heterogeneous. In every respect, severity of ASD, verbal ability, co-occurring conditions. Okay. So one thing that we've been focusing on is verbal ability. Does verbal ability predict a reduction in anxiety during treatment specifically with CBT? So these data come from the MASSI RCT, that modular CBT program that I talked to you about. And as you would expect, so all this time you've been seeing this. As you would expect, verbal ability does predict treatment response to CBT. We did this now with 2 different parent report measures of anxiety. You don't see a significant predictor. It doesn't have a prediction effect on pre-treatment anxiety levels, but it does in terms of change in anxiety. All right, and that this is all, again, this is HLM just looking at predictors at pre-treatment of where the kids end up. Okay, my conclusions. Number 1, ASD severity and verbal ability predict treatment response. ASD severity also predicts anxiety symptoms. I didn't show you these data. Okay, they're published elsewhere. So we need to be thinking about things like verbal ability and severity in terms of modifying and individualizing treatments, but perhaps things also like gender or type of anxiety. Number 2, heightened parental anxiety is associated actually with maintenance of treatment effect, and we need to figure out why that is. And third, there's preliminary evidence of sustained improvement with treatment. Okay, again, that's with CBT. The jury's still out on mindfulness and acceptance-based intervention. So I just said. All right, that's it. I'm sorry that I went a little bit over, but do we have time for a couple of questions? Thanks. Thank you. Any questions? Yeah.
Folks have talked about that, trying to bridge the gap between research and clinical application, anywhere from community mental health clinics to schools to private practices. What do you see as the greatest challenge of implementing the fruits of this highly empirical research in the trenches?
Yeah.
There's an easy one for you.
No, yeah, thank you for that question, and I don't mean that. So the question is essentially, how do we bridge this gap, all right?
How do you help us to more effectively overcome the logistical barriers that some of this research-driven treatment demands of clinicians? I know I don't mean it, it's it's a rhetorical question, really.
No, thank you for handing me a shovel on that one. I think that we are doing better, to tell you the truth, in the way that most of the trials are being designed now. In ASD and a lot of research outside of ASD, what we're really focusing on and what funders want to see is things like participatory action research. So what we have been doing, and just as a case in point, with this mindfulness-based treatment that I mentioned that we started a couple months ago, to make this happen took 4 years in the making to get the curriculum together. And that was because we got consultation from ASAN, the Autistic Self-Advocacy Network. We went to multiple people with autism, parents, clinicians across the country to say, oh, okay, will this be effective? You know, what do you need help with? And not just like the content, but what's going to help in terms of aiding delivery so that it's palatable to your clients, and so not just another thing that collects dust on your shelf. Okay? But the other side of that, and this is why I'm so hot on the technology end of it, is because this generation, like this generation being like the 10 to 18-year-olds right now, and of course the kids who are younger than that, it's taking much less time for technologies to get from R&D to the shelf than it is for our psychosocial treatments. So if we can merge the technology with therapy, I think that's opening up a wonderful Pandora's box. Thank you for your time.